You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for June 7th, 2024. This week, cannabis and cardiovascular outcomes, post-cardiac surgery AFib, embolic protection devices after TAVI, emulation of randomization, and an introduction to heterogeneous treatment effects. Let me start with some words on the British Cardiovascular Society meeting. I want to offer a huge thank you to Professor Andrew Clark and the British Cardiovascular Society for inviting me to give the Paul Wood Lecture at the BCS annual meeting on Monday in Manchester, my first time in Manchester. Thank you for the hospitality, and thanks to the many who came up to me afterwards and said they listened to the podcast. It's interesting how receptive a British audience is to a lecture on critical appraisal of evidence and lessons from cardiac history. Paul Wood practiced cardiology in 1940s to 1960s. He wrote what was then the definitive textbook in cardiology in 1950. It was 1,000 pages. Can you imagine one author? He became famous in Britain for his bedside skills, strong thinking, and a lack of fear of also speaking candidly. He died at age 55 in 1962 of an acute coronary occlusion. When he saw his ECG, he called it irreversible and told his caregivers that he should not be resuscitated. He had VF later that day. I started my lecture by saying that Dr. Wood had a different problem than we have now. Dr. Wood's problem was that he did not have enough to do for his patients. I mean, one of his papers recommended treating angina by telling the patient to cut down to 10 cigarettes per day from 20 to 25. Our problem now is that we have tons to do for or to our patients. The question is whether we should do these things, and that's where evidence appraisal comes in. So I told stories about evidence appraisal, including many of the major mistakes that we have made as a field. One theme was how we were misled by overconfidence in observational studies. I've been honing this lecture for a number of months, and there are really good stories to tell about using evidence, and it's really why I like doing this podcast. So the first topic today is cannabis for chronic pain and cardiovascular safety. There was a tale of two observational studies recently, one very strong and one quite weak. Dr. Anders Holt and his team, led by Dr. Morten Lamberts at the University of Copenhagen, have published a very nice study of cardiovascular safety for medical cannabis use as a pain reliever in the European Heart Journal. I should first set out that this is an important topic to study for multiple reasons, right? Chronic pain is a serious problem, not least because the relief of pain comes with the potential for adverse effects. Nonsteroidal drugs have well-known cardiovascular and renal complications, and the dependence issue with opioids surely is an even more serious complication. The other tragedy of our U.S. opioid crisis is underappreciated. Second issue is cannabis is pharmacologically active, and it surely has cardiovascular effects, and there is little empirical data on its use. Now, third, as always, you'd want to have proper RCTs to really know how cannabis stacked up with other pain relievers. But there are no RCTs, and there are not likely to be any in the near future. So observational data is going to be all we have with cannabis for a long time. And many countries have legalized medical uses of cannabis, Denmark included. Now, there was a recent JAMA Network Open paper, first author Lillian Gelberg. They report that in the UCLA system, nearly 1 in 5 people report cannabis use, and of those, about a third meet criteria for cannabis use disorder. So that was just a lot of words to say cannabis use is a big deal and is worthy of study. So let's go back to the Anders Holt Danish paper. Now, the Danish registry allows for really high-quality observational studies because part of the universal Danish healthcare system is that there is a national registry which captures everything, prescriptions filled as well as outcomes in all Danes that use the universal healthcare system, which is nearly everyone. When I was in Copenhagen, Dr. Lambert showed me the registry and a bit how it works. And it's an amazing resource for asking questions about associations, finding adverse effects of therapy, or describing temporal trends. It's really a national treasure, I think. Dr. Holt and his team identified patients. The median age was 59 who had chronic pain, who initiated a first-time prescription with medical cannabis between the years 2018 and 21. There were about 5,400 patients. They then matched these in a 1-to-5 ratio with 26,000 control patients who also had chronic pain. The matching included usual things like age and sex. The two major outcomes of interest were arrhythmias of any sort and acute coronary syndrome. And they included all sorts of patients with different kinds of pain, musculoskeletal, cancer, neuro, and about a third of patients had unspecified chronic pain. The 5,400 patients who filled the cannabis treatment could have taken different formulations of the cannabis, like CBD, CBD with THC, or THC alone. The key finding in this paper was a doubling of the risk of any arrhythmia in first-time users versus non-users. The absolute incidence was 0.8% versus 0.4%. The risk ratio, basically 2. Now, if they assessed just new-onset atrial fib flutter as an outcome, it yielded a similar results of risk ratio, about 2. That was comparing medical cannabis use with no use in chronic pain patients. And the Kaplan-Meier curves separated not immediately, but over time, as you'd expect if cannabis was causal. The higher risk ratio was seen in all subgroups, but it did not reach statistical significance in all of them. But the authors found no significant association with medical cannabis and ACS. The risk ratio here was 1.20 with very wide, non-significant confidence intervals. The absolute risk of ACS was also quite low, 0.2% in both groups. They also found no association with stroke or heart failure. Now, when they included concomitant treatment with other pain medicines, this did not change the doubling of the risk. But when they restricted the exposure to only patients as exposed if they filled a second prescription for cannabis, the relative risk declined to 1.4 and was no longer significant. That's interesting, isn't it, that second prescriptions were not associated with the elevated risk of arrhythmia. Now, my comments. This paper was originally published 3 months ago. I saw it because Holt and colleagues ran another analysis that the European Heart Journal just published. It's such a nice story. A writer wrote to the European Heart Journal to ask about what the analysis would like if Holt et al. Considered lifestyle factors such as smoking and alcohol use, because they could be important factors or variables. And guess what? Holt and colleagues obliged, and they ran more analyses, and they published them just recently. And it turns out that patients exposed to medical cannabis were more likely to have a history of smoking than control patients, whereas alcohol abuse rates were similar. Adding the smoking and alcohol proxies as variables to the statistical models yielded comparable results compared with the main analysis. Likewise, if the association between medical cannabis use and cardiovascular risk was assessed in a subgroup free of smoking and alcohol history, results were also comparable. Now, what should we make of this? First, I think it's plausible that cannabis could increase the risk of AF. The active components have effects on cardiac electrical properties. It's also possible that medical cannabis has no association with atherosclerotic events, at least early on. Here's one possibility. The positive effects of the drug on pain relief could balance any adverse effects on the likelihood of vascular events. I don't know, it's speculation. The editorialist for the paper points out that this observation differs from other observational studies that do find higher rates of MI with cannabis. So the analysis, of course, is observational. Unmeasured confounding is always possible, and the authors write about it. There's also the issue of how cannabis is delivered. Smoking would seem more hazardous than other ways. Now, there was also another paper on cannabis use. This was in JAMA Network Open. Remarkably, it was written by one person, Alexandre Vallee, I'm sure I pronounced that wrong, an epidemiologist from France. He used a UK biobank to ask about the cannabis use association with all-cause CV death and cancer mortality in males and females. This was a very simple association study. It basically correlates cannabis use into high, moderate, and low in the different sexes, and then looks at rates of death, CV death, and cancer death. And he finds a positive association between CV death and heavy cannabis use among females. Now, in the discussion, he spends many words describing the limitations of this analysis, and it is really weak analysis. There is adjustments, but it seems obvious that self-reporting cannabis users would be different in many ways from non-users, many ways that you couldn't control for. He actually makes a case himself for reverse causation, wherein the cardiovascular diseases causes the cannabis use. He writes that there was no information on the type of cannabis or its delivery. He also included no falsification analyses, and I'm surprised that such flawed analyses are published. You should read the Danish paper in this one and contrast the quality. Now, I report on these observational analyses because there's so little RCT data with cannabis. We can't make definitive conclusions from any cannabis paper, at least yet. In this case, the Holt et al. Paper from Denmark is strong, but it's still non-random and only looks at the 180 days after the first prescription of medical cannabis. Chronic pain therapies have to be proven safe and effective over a lot more than half a year. But perhaps the lack of short-term ACS signal is mildly reassuring. I mean, if cannabis helps with chronic pain and the only costs are a small absolute risk in AF and no elevated risk of MI, then that could be a good thing because patients with chronic pain have so few good options. The U.S. population has just recently woken up to the dangers of opioids, and boy, did we get bamboozled by marketing. In recent years, I've become so frightened about the danger of opioids. If cannabis helps reduce opioid exposure and it proves reasonably safe, it could be a win, so I'm open-minded. But this is the first mile of a marathon in understanding cannabis use as a therapeutic. All right, next topic is post-cardiac surgery AFib. Oh my gosh. AFib that occurs after cardiac surgery has to be one of the most vexing problems in all of cardiology. In 30 years, I've come to believe the only way to prevent AFib after heart surgery is not having heart surgery. Nothing seems to work for prevention. But that's not the only question. Another major question that comes up often is what to do about stroke prevention. Should patients get oral anticoagulation? On the one hand, cardiac surgery patients often have many stroke risk factors. Their CHA2DS2-VASc scores are almost always high. Plus, they just had surgery, so thrombotic risk would seem to be high. But on the other hand, they just had surgery, so bleeding risk is elevated. Sadly, it would be an awesome question to study with randomization. You just randomize one group to anticoagulation, another group to not, and since there's equipoise, but I know of no such study. We only have observational data. Okay, a group of authors from the Netherlands. First author, Marleen van der Kar, I think, have put together a huge meta-analysis of observational data on the effects of oral anticoagulation for post-CABG AFib. The paper's in the European Heart Journal. The study included 28 studies and 1.7 million patients. Also, these were post-cardiac bypass surgery patients. The overall mean incidence of post-cardiac bypass surgery AFib was 24%. The range was 8% to 38%, which seems pretty low, but perhaps it's low because it's just bypass surgery and not valve surgery. They first summarized the incidence rates of stroke. In-hospital stroke rate, 1.6% at 1 month, 1.0% at 1 year, 0.6%. Those are important. They then compared stroke, death, and bleeding rates per 100 patient years for postoperative AFib versus non-postoperative AFib over 5 years. And they found that patients who had post-cardiac surgery AFib had slightly higher rates of thromboembolism, 1.7 versus 1.1 per 100 patient years, mortality 3.4 versus 2.2, and bleeding 2.0 versus 1.6 per 100 person years. Now, before I tell you about the effects of oral anticoagulation on this, look at how low the rates of stroke are at 1 month and 1 year. They're 1% or less. There's also very little difference between stroke and bleeding rates over 5 years when you look at the rate per 100 patient years. So you should have a clue of what the studies that looked at oral anticoagulation versus no anticoagulation will show. There was no association with lower stroke or mortality with oral anticoagulation versus non-oral anticoagulation use, but there was a 32% higher rate of bleeding in the oral anticoagulation users. So my comments. This data tempts you to conclude that post-cardiac surgery AFib is a little similar to subclinical AFib in that it is associated with a low risk of stroke and no benefit from oral anticoagulation. Now, I chose the verb tempts you because it's still observational data. The way to answer this is with an RCT, but this is all the data we have, so we have to use our brains. What can we say about this? Here is how I see it. Now, this is very speculative. The level of evidence is very low, but here's how I think. First, I don't think the CHA2DS2-VASc should apply at all to post-cardiac surgery patients. That score was not derived in post-bypass patients with AFib. Second thing, we can be reasonably confident that oral anticoagulation indeed increases the rate of bleeding. Third, we can also be confident that the stroke signal of low stroke incidence after post-cardiac surgery is probably pretty close because strokes within 30 days after a bypass is unlikely to be missed, I think, by studies. The problem comes in sorting out the lack of stroke benefit. Clinicians, not randomization, decide to use or not use oral anticoagulation, so the groups will likely differ in important ways, and so it is hard to make much of the lack of signal of benefit. It could be a false negative, though I doubt it. In the end, what I do when asked about anticoagulation after these patients is I think we have no evidence of benefit. We know the stroke risk is likely low on average in general, and we know that bleeding risk will be higher with oral anticoagulation, so I lean slightly against the use of oral anticoagulation. But I know that we need a proper RCT. Perhaps listeners of the podcast know if one is ongoing or planned, and you can let me know. All right, next topic is kind of a double topic. It's embolic protection after TAVI, and it's a little bit about trial emulation. Now, it shocks me that stroke rate is so low after TAVI. Let's just set that out. These are older patients with thickened, calcified aortic valves and likely diseased aortas. At the risk of dumbing the whole thing down, the new device, the TAVI device, actually squishes and crushes the diseased valve, and you would think that debris would just be flying everywhere. And if I did not know better, an embolic protection device placed between the aorta and the brain would be a necessity. But it's not quite that obvious. Things in medicine are not often as they seem. Embolic protection devices do indeed catch debris after a TAVI, and these make for dramatic pictures, like coronary angiograms. But the protected TAVR trial failed to show a statistically significant reduction in all-cause stroke, though there were wide confidence intervals allowing for benefit, and there was a signal, a 62% reduction, that the device reduced disabling stroke. The kind of stroke that would be prevented if the device caught large debris. Well, Circulation Outcomes has published a new observational study looking at use and non-use of embolic protection devices, first author Neil Butala. Even though it's an observational study, I like the paper. There are worthy things to say about the methods and the results. Now, Butala and colleagues used the STS-ACC TVT registry to compare outcomes between patients who had the EPD embolic protection device and no embolic protection device. The authors were interested in disabling stroke, but that's not labeled in data sets. So they used in-hospital stroke resulting in death or discharge to a non-home location as a surrogate marker. It's actually pretty good thinking. They had data on more than 400,000 TAVIs. About 13% or 54,000 of these had an embolic protection device, and the rest did not. Now, these are obviously not randomized comparisons, so the authors had to try and simulate the normal balancing of factors that would occur with randomization. They did this in two ways. One way was the usual propensity matching, wherein patients are matched using variables from the data sheet. But the other way is what's called an instrumental variable or IV analysis. I'm going to go out on a limb here trying to explain instrumental variable analysis, so give me a lot of leeway, please. An instrumental variable analysis can be used to overcome confounding by indication. An instrument is something that is relevant to the outcome and determines the treatment, but not affected by the treatment. So consider, for instance, physician preferences might be an instrument, because when there is equipoise of treatment, the choice of using or not using the treatment could be the doctor's choice, sort of like just a fashion or a practice pattern, if you will. And that can be quasi-random. And then, if it's quasi-random, any differences in outcome would be due to the treatment, not other factors, like the overall health of the patient, for instance. The instrument they used in this case was site-level preference for embolic protection devices. Site-level device use would seem a good instrument because it theoretically leads to quasi-random groups. So if you look in the supplement, they have two columns of patients, those with hospital device use within the same quarter and those without hospital use of device in the same quarter. There was 168,000 in the device use group and 250,000 in the non-use in the same quarter group. And the main findings were that the unadjusted rate of in-hospital disabling stroke was 0.7 in the embolic device protection group versus 0.9% in the no EPD group. And now they did the adjustments. In the instrumental variable analysis, the relative risk was 0.87, a 13% reduction in disabling stroke. The confidence intervals went from 0.73 to 1.00, so not quite significant. Now, in the propensity-matched analysis, the hazard ratio was better at 0.79, and that 21% reduction had confidence intervals from 0.7 to 0.9, so that was significant. And their second finding was that, like in the protected TAVI trial, EPD use was not associated with non-disabling stroke. A third finding was that when they looked at subgroups, the benefit of the EPD device was much greater in those who had prior stroke versus those without. In this group, the EPD device reduced disabling stroke by 35% versus only 6% in those patients without a prior stroke. Now, the authors made some big conclusions. They write, quote, in the largest study to date among patients undergoing TAVI, EPD use was associated with a small, borderline significant reduction in stroke associated with death or discharge to a non-home location, which is a proxy for disabling stroke. This is likely to be causal in nature. Taken together with previous mechanistic and clinical studies, these findings provide credible evidence that EPDs benefit patients undergoing TAVI. Now, my comments. I like this analysis. While it's observational, it is a really thorough analysis with a good effort to simulate randomization. Senior author David Cohen wrote to me on Twitter that the instrumental variable analysis does not assume that hospital use of the EPD is random. It assumes that patient distribution across hospitals is random. And to me, that looks to be borne out when you look at the appendix or the supplement in that the two groups are well matched. Now, the other thing I like about this is that it's clear that the authors are trying to compare EPD use and non-use. They are candid about their attempt to make causal conclusions. Just like I covered a few weeks ago about the JAMA editors saying that we need to just be clear about what we're doing with these observational studies. These authors do not disguise this randomization emulation attempt with mere associations, and I actually think they get quite close to randomization. In fact, they did emulate the results of the protected TAVR RCT, but they also did something else. They showed clearly that this device is not cost-effective, not at all. The tip-off for me came in the middle of their discussion when the authors noted that the nice-sounding 13% reduction in the instrumental variable adjusted analysis translates to an NNT of 833. So even if the device costs very little, $100, it doesn't, it costs more, we'd have to treat 833 patients to prevent one disabling stroke. That was such a huge NNT. I went back to the absolute risk reduction, and indeed, it was 0.79% versus 0.91% in the EPD versus no EPD group. That's a delta of 0.12%. Now, the authors spend the next paragraphs telling us how big the next study would have to be based on these small differences. Translation would have to be very large, like more than 100 patients large. They also write that there is certainly enough equipoise here to continue the UK-based British Heart Foundation PROTECT TAVI trial, which has a target of just 7,700 patients. So just based on this, it's likely to be very underpowered. In conclusion, this is a really tough dilemma, isn't it? This device probably has a tiny, tiny, tiny effect on disabling stroke. Real-world data with careful adjustment replicates the findings in the RCT, but how can we justify this expense when it's that small of an effect? I mean, there has to be a line somewhere. Like I said at the outset, Dr. Paul Wood in the 1940s and 50s did not have enough to offer his patients. We have plenty. But when the NNT is 800-ish or even 500-ish, well, that too is a problem. The authors tell us to consider the smaller NNT in the patients with prior stroke, but it's still going to be a very small absolute risk reduction, a large NNT. This is a subgroup analysis of an observational study, so it's hard to put much weight on that. I'm super interested in any comments you would have or thoughts on what to do in this case. And I want to do a little tiny, tiny preview of next week. And it has to do with subgroups within studies. I saw on Twitter this week an incredibly interesting paper on treatment effect heterogeneity, or HTE. I will link to it so everyone can read it. We can talk about it next week. The first author is Dr. Herbert Weisberg. It's in the American Heart Journal, and I'll link to it in the show notes. The reason this is important is it pertains to the embolic protection device story that I just told. Overall, the devices have little average effect, but proponents, and really me too, would like to try and hone into patients who might benefit most. In other words, we seek evidence for and direction of a treatment effect heterogeneity within the large trials or large studies. This new paper in American Heart Journal delves into ways to find such things, which is really the essence of medicine, because average effects from trials help us somewhat, but we often see patients that are not at all average or similar to those in the trials. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review, tell me what you think. It really helps others find us when we get ratings and reviews. So whatever podcast you have, go ahead and give us a rating. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.